total of 108 residents, but I think about 30 were at the site that was involved in the program, about 83 internal medicine residents overall, 25 pediatrics, and the projects that they were involved in included care transitions and medication reconciliation, as well as CLABSI and VTE on the inpatient side. And then Andy Racine is the Senior Vice President and Chief Medical Officer at Montefiore Medical Center. Montefiore had about 11 sites, about 351 residents, 245 internal medicine, 8 pediatrics, and 29 family medicine. In their projects, 3 sites did integration of physical and behavioral health, 8 sites did care transitions, medication reconciliation, and as well as sepsis and surgical care improvement on the inpatient side. So they may correct or amplify some of the information about their institutions or their projects, but what we wanted to do is really ask them a few questions and have each of them take some moments to talk about this, a few minutes each, and I think there'll be a card if we think you're going on too long, to really reflect on a couple of the major areas that we think are worth talking about. And they include some conversation about the patient-centered medical home recognition process, talk a little bit about integration of care, and then residency training. So I'm going to start things off with Tom, and the question for each of the panel to reflect on is, patient-centered medical home was really kind of the centerpiece of the project, and as I talked about in my opening remarks, there's, excuse me, ongoing conversation about whether that's enough, whether it's sufficient, whether it's necessary but insufficient. Is it a paper exercise? Is it a one and done? Does it really meaningfully change things? So I guess I'd be curious about your thoughts about whether moving in that direction, whether you did it in this project or previously, was significant in terms of the 2 goals that we have for the project, which is to really improve care for patients and improve the training experience for residents, and your thoughts about whether it did or didn't, and if it didn't, what needs to be done to make it so.
Well, I could make it very simple by just saying yes, but I think I'll say a little bit more. Actually, make just a general comment first, and then respond a little bit to PCMH. From my perspective, Hospital Medical Home has been a perfectly timed initiative to help our clinic begin the move from fee-for-service environment to a value-based payment environment. A whole change and revolution that we're in the midst of, and particularly to get ready for DSRIP. I mean, this has really, really helped us for DSRIP coming down the line. But probably more important is to train our residents to have the skills to not only flourish, but be leaders in the new value-based payment system by learning about leadership skills, team-based care, population health, quality improvement, all the things that we've been involved with Hospital Medical Home. So from my perspective, not only was it perfectly timed, but was incredibly helpful in that transition, because the world is changing so rapidly, and getting this kind of help has been extremely helpful. I should also say something about being in a family medicine department, because I'm sure it's very different internal medicine and peds, which we'll hear about. I mean, our residents do continuity throughout. They're all going into primary care. They do 3 to 4 sessions a week. So this is something we've been working on for a long time, and Hospital Medical Home really helped us with just moving it along, more robust, moving towards patient-centered medical home. As we all know, getting certified doesn't mean you're really patient-centered medical home. It just means that you have that little plaque you can put on your wall. Now, the 2014, we probably are going to have to really get a lot closer to get there. And I'll say in general, becoming PCMH and focusing on that has been extremely helpful, because it forced us to do all the improvements that you just saw on the slides. All of those improvements are all part of being a patient-centered medical home. And it is the future, obviously. Advanced primary care and patient-centered medical home, all the healthcare reforms are based upon that. So this is where we all need to be going, and it was helpful to move in that way. I will say, I was very concerned, as I'm sure all of you were, to hear about the cuts in payments for level 3 patient-centered medical home that are going into place in, 2 weeks, I believe. And those, I think, are really going to make it more challenging us to get to 2014 that we need to do. But that's where we need to go, and Hospital Medical Home was very helpful in moving towards that, and helpful for the training of our residents.
Great, thank you. Andy, you want to go next?
Sure, and I'm going to echo a lot of what Tom had to say, because I think the experiences that we had in the Bronx are not that different from what was going on in Rochester. The one thing I will say that was different is that this was a seed that was planted in fairly fertile ground within our institution, and the reason I say that is because long before I assumed the position that I'm currently in now, the institution had made a decision really 20 or so years ago that it was going to migrate from a fee-for-service environment into a value-based environment. And that has had enormous implications with regard to the architecture of how we practice primary care throughout our system. So in 1995, when the first risk-based contract was entered into in large numbers at Montefiore, they created a system, a care management organization that would sit side by side with the primary care environment that would help take care of patients during the periods of time that they actually weren't side by side with the physicians and the nurses in the practices. So there was an architecture in which patients would have contact with folks, care managers, pharmacists, social workers, mostly telephonically, that would help manage their care during that period of time. The HMH grant that came about was therefore kind of pushing it an open door. With respect to this large primary care network that we had set up, we already had certain architectural elements in place that were going to allow us to take full advantage of this initiative. We were pushing already towards patient-centered medical home recognition in all of the sites that we had. We had multidisciplinary teams that had been established to work on quality improvement projects. We had coaches that were going out to all of those teams to try and tell them a little bit about how PDSA cycles work. We had a learning collaborative where those 23 sites were coming together on a quarterly basis to review the data. We had a data system in place where people were actually culling data out of our clinical information system to feed to folks. So what was missing, the element that the HMH project allowed us to do, was to pull the resident and the training sessions into that architecture and into those programmatic structures. And I think that we had done some work in that. Actually, I have some colleagues here in the audience. Dr. Bruce Soloway, who is the vice chair of family medicine, had gone a long way to try and get to the attribution issue, which is one of the things we struggled with, talking about Dr. Singer and our failures. One of the big things that we struggled with is how do you attribute patients to residents and whose patients are whose? And Dr. Soloway actually worked on an algorithm that allowed us to mine to go into our clinical information system and sort of figure out who was actually seeing who. That made a big difference when it came time to empaneling patients. So I will say that Tom is absolutely right. This was a great initiative that was timed precisely right to try and, from our standpoint, exploit some of the things we had already started, but without which I don't think we would have nearly achieved some of the recognition that we did. So it was I think, a great example of how government works really well.
I'm retiring after today. I have now heard it all. Joanne. Thank you, Eddie.
Many of my comments are similar. I'll just clarify. Our site is an internal medicine training site only. Our program actually has 134 residents, 80 of whom or so train at this site, the remainder at a non-PCMH site. We also had things in place for the site. We had been a level 3 PCMH by 2008 criteria in 2009. And had been underway with planning when this demonstration program came along. We had a lot of support from our institution, echoing what you said, with EMR upgrades for IT and issues of interoperability and team building. Our health system having given us many resources, including embedded case managers and others. But the program did definitely push us forward, and I think allowed us to have a lot of clout in terms of things we were trying to accomplish. Moving to the head of the list for our IT upgrades, as an example, we did add some additional members of our team. All of that was helpful, very much so. I will comment on whether the PCMH improved resident training from our perspective. We did not have a specific curriculum in PCMH, although the program does plan to roll one out for the next academic year. We do all believe, however, that training in a PCMH did help resident education. The sense that the faculty who precept the residents were of the PCMH mindset, the fact that the residents worked in all of the activities and got to know members of the team and understand the various team roles, the fact that they did get data, and we had a fairly large empanelment initiative, which we'll touch on later. So we think that training in a PCMH really did make a difference. What the residents say, is another story. And the other comment that I'll make is we did participate, our program did participate in a survey, a locally geographic survey of residents' perceptions about PCMH, and it was self-reported, but it included residents that did train in a PCMH and residents that did not, and those that trained in a PCMH felt more prepared for the PCMH-like activities like care integration and collaboration and those things.
Great. Thank you so much. I neglected to mention that we're going to, I think we'll be able to leave about 10, 15 minutes worth of questions of the panel or comments, so be sure to write down or remember, if you can do it without writing down, if you're younger and smarter than I am, questions or comments that you might want to follow up on with any of the panelists. We'll get to that after a couple, the next 10 minutes or so. I wanted to, one of the key strategies or one of the key challenges in healthcare that I think many of the initiatives that Dr. Zucker talked about, and Peggy's going to talk a little about DISRIP later this afternoon, and that Dr. Singer, Andrew talked about as well, is that the difficulty and the environment of sort of lack of integration or connection, whether it's communication or understanding language or each other's cultures among professionals in healthcare, let alone sort of the gap and challenges across between healthcare and other professions. One of the things that struck us as we were beginning the program was the divide very frequently, of course not at your institutions, between the hospital, the residency program, the site director. There were folks who, the sense was they may not have even known who each other was, what they did, would not been used to working together as closely as some of the project demanded. And clearly, part of DISRIP and PPSs and ACOs and integrated care or new payment models are forcing some of those walls to come down. It's not an easy process. There's a real challenging thing to do. But a key